And so, again, this is something that, anybody who works with new mothers can do, so it can be done even at the community level. But you want to think through before you screen, you want to think through, okay, if it tests positive, what are you going to do about it? Now, you might say, well, I don't have the resources. I can't possibly do anything about this. I can't treat it. Well, yeah, that's likely true. But there's probably people in your community who can help you take next steps. So what you want to do before you ever give a mother a form is you want to actually think about, okay, if this is positive, what's going to happen next? Hey everyone, welcome back. This is the Science Chick Report, and I'm Dr. Kathleen Kendall-Tackett. I'm going to record actually 2 sessions today talking about something that's really important when you talk about perinatal mental health, and that is how you do an assessment. So we're going to talk a little bit about the why you do an assessment, but also what that means and what to do about it. In the next session, what I'm going to do is I'm going to walk through a couple of the more common measures so you kind of have an idea of what it is to do. So I think actually screening is one of these things that's really important because anybody can do it. You may not necessarily be a mental health provider, but it is something that you can do no matter what your position is. If you work with new moms at all, these are tools that are readily available. And also there is some good that comes from it. Now, again, you're not trying in most cases to make a diagnosis, but what you are trying to do is actually, become a sort of gateway into the healthcare system. So many times, women are depressed, but they don't talk to anybody about it. And so, there's lots of opportunities, if you're in the community to actually just administer one of these tests and then point toward areas that people can get help. Now, let's talk a little bit about, a couple of the things that we do know about screening depression. This might seem like it's kind of a, boring or sort of mundane topic, but it really isn't. It's something that's so important because it's the first step, and you won't be able to ever tell somebody is depressed if there isn't some kind of measure of it. Sometimes you can see it when you're just looking, but oftentimes mothers are embarrassed. They hide it. So getting a kind of a good beat on it using a measure, I think can be a first step. And again, many people who work in the community, it's not really their role to try to diagnose it. But what we're doing and what I'm actually going to be talking about is not diagnosing depression, but looking to see if there's maybe some symptoms there that warrant further follow-up. And that can easily be done. So here's a couple of kind of things that I think you should know about screening. And this is, again, kind of an important area because, it's something that gets neglected. A lot of people say, oh, yeah, this is important. You should do it. And then they don't do it. Okay, so the first one is this, that healthcare organizations recommend screening mothers for depression, but most new mothers are never screened. And that's kind of astonishing figure when you think about it. You got 3.5 million women give birth in the United States every year. And most of the healthcare providers that they interact with never once screen them for depression. Okay, but also, too, there's some barriers to this. And you would think, well, gosh, if this is a good idea, why are there barriers? Well, there are a couple. The big one, of course, especially for healthcare providers, is time constraints. Oftentimes healthcare providers are in a situation where they've got a limited amount of time to see people in their office. So appointments may be 5 minutes, 10 minutes. And so screening a lot of times kind of takes time, and it kind of can mess up a schedule for the day. Like if you're going through and, somebody all of a sudden is, showing positive for depression, all of a sudden they may require extra time. So this is why a lot of providers kind of choose not to do it because, they recognize the reality of their situation, but sometimes they think, oh, I don't want to get into that. That's not really my area. Okay. Now, the other thing is, and this is, I think, related, is what do you do if it screens positive? And I think this is something that a lot of times people don't think through. And boy, I'll tell you, this is something that I have seen people have a lot of misconceptions about screening about because they think, oh, yeah, I gave somebody the Edinburgh postnatal depression scale, but then they have no idea what to do about it. A lot of times it's never even scored. It might just be in a packet, but people say, well, yeah, we screened for depression, but they never looked at it, or if they did look at it, they didn't do anything about it. And so it's kind of useless to screen if there's not some planned action, and so again, this is something that, anybody who works with new mothers can do, so it can be done even at the community level. But you want to think through before you screen. You want to think through, okay, if it tests positive, what are you going to do about it? Now, you might say, well, I don't have the resources. I can't possibly do anything about this. I can't treat it. Well, yeah, that's likely true. But there's probably people in your community who can help you take next steps. So what you want to do before you ever give a mother a form is you want to actually think about, okay, if this is positive, what's going to happen next? And I find so many providers don't do that. They somehow think they've done their due diligence just because they include something like the Edinburgh postnatal depression scale in their patient pack. I can't tell you the number of times I've filled out, some of the other depression measures like the PHQ-9 or the PHQ-2. Sometimes I filled those out at doctor's offices and nobody ever says anything, and I think that that's kind of par for the course in a lot of providers. So again, I think if you're going to be really helpful here, what you do need to do is think about, okay, what's going to happen next? What are we going to do? Okay, now, and kind of also related to that is this idea that if you ask, you're going to be, quote, opening Pandora's box. So this idea is that you ask somebody about depression, they become very, very upset, and then you're having to sort of deal with that as an aftermath. And, a lot of providers think, oh, I'm not really comfortable with that. I'm not really going to be good. I mean, that's assuming that most women react like that. Many do not. But that's actually one of the big reasons why, for example, healthcare providers, say in emergency departments, oftentimes don't screen for domestic violence because they think, oh, Pandora's box, and oh, that's going to just open up all this emotional stuff that I'm not ready for. But also, too, what are we going to do with it? So you can kind of see how all these things are sort of tied together. You want to have a plan of what's going to happen, but also be realistic. Like, for example, if you're in a situation where you don't have very long to see mothers, is there somebody in your office or in your organization who can do this part of it? And so then kind of divvy up the task. But what you want to do is, don't start handing out measures if you don't have an idea of what's going to happen next. Because sometimes mothers think, oh, good God, I'm glad somebody's asking about this finally. And then they get screened and nothing happens. Nobody ever talks to them. So it's kind of like setting up a situation where they might be thinking, oh, good, I'm finally going to get some help. And then nobody does anything. So again, really thinking about that, really thinking about the Pandora's box. And what would you do if that situation had happened? And how would you handle that? And again, in most cases, it's not going to be that. And so that's not really a good reason not to do screening. But what we want to do is we want to make sure that you kind of can handle things and handle things in a way that is fair to mothers, but also kind. Okay. But the other thing is, and this is kind of a crazy thing, is they found actually a lot of providers believe that they can identify depression without using a measure, and every time that's been studied, it's been proven to be spectacularly untrue. So people think, oh, yeah, I can tell. I don't need to have a measure. I don't need to do anything, and so therefore then they think, no, I don't need to use a form. I'll just know. Well, providers are actually notoriously bad at that. So what I'm going to talk about is kind of, first of all, let's just recognize what these barriers are and kind of talk that through and then think about, okay, how can we address these barriers? And so like, for example, let's say you work with an organization, but other people are very hesitant. It's really helpful sometimes to make these concerns explicit. Let's talk them through. Let's have a plan. And then you can go ahead and do it. Because, if you find out that most new mothers are never screened, and that screening does make a difference in terms of women getting the support and the treatment that they need, it really becomes kind of ridiculous when you find out people don't. Okay, so the U.S. Agency for Healthcare Research and Quality, or what's known as ARC, they've actually talked about screening. Okay, so they did that in a 2013 article, and they were talking about the components necessary for a screening strategy. And they said, well, first of all, you need to know which screening scale to use. So we'll talk about that in the next session. But also when to screen, who should screen, and how do you use the results? So that sounds pretty straightforward, right? These are all the things that I'm saying that you should actually have planned out. Okay, so to give you an example of kind of why I think this is not done, is because sometimes people are very nebulous about all these different parts of it. So for example, in a 2013 statement, the American College of Obstetricians and Gynecology Committee on Obstetric Practice. Okay, so these are the people that, the professional organization for all the OBs, in North America. And they actually recommend this. They said that there's routine screening by physicians is important for ensuring appropriate follow-up and treatment. Okay, so that's all they said. They didn't really kind of talk about kind of what's important, why, what measures. Now, let's contrast that to the UK National Institute for Health and Clinical Excellence, which is an organization called NICE. Okay, and their policy is actually much more specific, and I think it's actually a much better policy. Okay, so they specifically recommend who should screen, the primary provider, when it should happen, and they said at first months, at 4 to 6 weeks, and 3 to 4 months, which professional should do it, all, and what to ask. And they actually specify several scales, including the Edinburgh Postnatal Depression Scale, the Patient Health Questionnaire 9, and the Hospital Anxiety and Depression Scale. Okay, so you can see their guidelines are much more specific because if you say, well, it's important to do it, a lot of times providers are read that and they're thinking, okay, well, someone else will do it, versus this one specifies everybody who comes in contact with mothers should be doing this, and so you can kind of see why, in a lot of ways, there's more screening there than there is a lot of times in the US. Okay, so let's talk a little bit about this idea of Pandora's box. Unfortunately, this is an article that actually describes this. This was from Lang et al. 2022, and they talked about this dilemma about screening among healthcare providers in Canada. Okay, so they're on a national health system there. And what their recommendations are is that they are against universal screening because they are worried about false positives that could, quote, overburden their primary care providers. So they are actually kind of in some ways recommending the Pandora's box approach. Don't look because you're going to have a lot of work if you do. And yet, in their country, roughly 23% of their mothers have either postpartum depression or anxiety. So it's called, let's bury our head in the sand and this will go away. So that's according to Statistics Canada in 2019. So again, when you see something like Pandora's box actually institutionalized, it's pretty amazing. Okay, but another thing is they talk about a recent article by de Klerk et al. In 2021, and this is from the Listening to Mothers in California study. So they had 2,539 women in a representative sample of birth certificate files. Now, what they found is that, screening can also be a very important equity issue because they found in their sample that non-Latina Black women had higher postpartum depressive symptoms and lower use of medication and counseling compared to non-Latina white women. Okay, and they found that actually those women were less likely to be screened. Okay, and yet the women who were screened were 6 times more likely to receive counseling. And so they argued that universal screening was important because it would reduce inequities and help address underuse of counseling, especially for women of color. So you can kind of see that that is a very important kind of issue. Okay, so another kind of thing that is an argument for screening is this was a study using PRAMS data in Utah. Okay, and they actually found that 66% of women with depressive symptoms did not seek help. Okay, so you've got a lot of women out there with symptoms that are not getting any kind of assistance and help. So again, they're not volunteering this information to the providers. It really needs to be found via screening. Okay, so let's talk about pediatric settings. Okay, so this is in some ways a very logical place for screening to occur. And yet, it's kind of a strange place because in the US, many women will go from seeing obstetricians for their health care. And then the next providers they tend to interact with a lot over that first postpartum year are the baby's providers. And so the argument kind of almost makes it itself. You know, babies providers will think, well, these women aren't my patients, so why would I screen them? And so again, they also raise the issue of Pandora's box, but they may feel like they don't have time. They got a lot of kids to see, and they don't have time to deal with a depressed mother. But what's interesting, and many people in this field don't necessarily know this, is that the American Academy of Pediatrics has officially recognized that maternal mental health does fall within the purview of pediatricians. And the reason is because it affects the children. And this is what they said in Rafferty et al. 2019, is that perinatal depression is a pertinent issue for primary care clinician because of the significant risk to the health and well-being of the infant and family. Pediatric care practices can build a system to implement postpartum depression screening, to connect affected families to supportive community resources, and to refer parents for additional treatment when indicated. So the AAP is, actually recommending that these providers will actually screen the mothers that come in with the children that they see. Okay, but they also note that depression increases the risk of breastfeeding cessation, family dysfunction, and even child maltreatment. And that they feel that screening and referral to community resources is important for supporting healthy family attachment and parent-child relationships. So again, sounds pretty important. Okay, so going back to Canada was actually talking the big population study where they used the Edinburgh postnatal depression scale, but they found that actually the percentage of mothers that were screened in pediatric settings has actually dropped from 80% in 2012 to 70% in 2016. But they did find that older mothers were least likely to be screened. But in contrast to previous studies, the lower income mothers were more likely to be screened. So that actually is kind of a good development. Okay, so in pediatric settings, they actually identified a few of the barriers for why pediatricians don't want to actually do screening. Okay, so they said that first, this Rafferty study, again, kind of going back to those guidelines, and a study by Hedden College looking at pediatricians, they said that out of 1,600 AAP members that were trained to do screening, residents had the highest percentage of training, but it was only 20%. So you can see a gap right there. A lot of times they're not being screened on how to use these tools. And they said that older pediatricians had the least amount of training and the lowest level of interest in mothers' mental health. But they said even with residency reforms, 81% of current residents had no training in adult mental health issues. So you can kind of see that, their professional association is saying one thing, but actually what's happening in the field is quite another. Okay, so they another study by Hennigan, I thought this one was kind of interesting. They found that pediatricians were more likely to identify depression if their practice provides child mental health services, so they're already tuned into mental health issues. They thought maternal mental health influenced child health, and they believed it was their job to identify and manage depression. So again, I think that kind of gives you some ideas about, how to get pediatricians involved and what kinds of things to say. But again, screening can take place in a lot of different settings. But what's really ideal is if you've got a lot of people kind of looking at this, it kind of shares the load a little bit. Yeah, pediatricians can treat depression, but in children, but they can't obviously treat in moms, but they can be the gateway to healthcare. But it's also true that actually they can be even helpful, like their staff can help, like, schedule appointments for moms, because sometimes right in the middle of depression or anxiety or PTSD, and, in top of caring for a new baby, you a lot of times have a very hard time navigating this system. And so, many, even though in this one study they had 2,100 pregnant women, and about 26% actually screened positive for depression, but only one woman out of that whole sample actually pursued follow-up treatment. So that's something else that can be really helpful, is not only to sort of identify sources, but even, go so far as to help get mothers scheduled. Okay, so let's kind of switch gears and talk a little bit about screening in obstetric settings. So obviously the 6-week check, or if it's, post cesarean, maybe the 2-week check can be kind of a good place. And there was this, some guidelines from the American College of OBGYN and the U.S. Preventative Services Task Force. Okay, and so they recommend that all perinatal women be screened at least once during the perinatal period. But again, you can see these guidelines are still kind of vague. They don't tell you who, they don't tell you what instrument. Um, and they said to use a standardized form. But this guideline to screen, quote, at least once is actually a little too vague. So then people kind of think, oh, I'll do it next time. But they said the sad reality is that large numbers of women suffer from mental health disorders during their childbearing years. The OBGYN is the only primary care provider for many women and has great responsibility to address the mental health of patients along with their physical health during and after pregnancy. So, a lot of people are kind of calling for this, but it isn't, we're still a long way off. And this is, again, why I think it's one of the things that's really important. Many of the studies really only talk about medical providers doing it. But I think actually really the best result is if you can get lots of people involved. If you can get people involved that work at various levels and in various functions. Okay, so this was kind of an interesting study by Kim et al. In 2009, and they looked at 19 obstetricians and 3 midwives, and most of them acknowledged that it was actually important to screen for depression, but few consistently did it. But 95% of providers overestimated their rates of screening, and 67% thought that they had achieved universal screening, even though they actually obviously hadn't. But the results actually showed something different. If the providers did not directly screen, in other words, they had their staff do it, only 37% did it. Okay, so some of them are thinking they have near universal screening, 67% thinking that they've got, universal screening, and yet only 37% of their mothers are being screened. And if they did it themselves, then they said about 59% actively screened. So in other words, just assigning it to somebody else hasn't been effective. I think it can be with appropriate monitoring. But they said that, they were concerned about doing the PPD screen for everybody because not everybody needs it. And they said that there was no time to do it, and they lacked the expertise on mental health issues. Okay, so another follow-up study looked at ACOG screening guidelines. This was published in 2023, and they said that, before and after guidelines percentages were 15 and 17% respectively. That's how many people were screening. So it's a tiny, tiny percentage. But then they looked at age, delivery complications, and geographical region. So they actually had a very large sample, but they said that prior to 2015, there was no reason to recommend universal screening. So again, I think this is one of the reasons why ACOG has been actually so lax about this and so general. They didn't really think that most people needed to be screened. But when they actually were talking about the number of women they identified, they used kind of a weird standard. They had a very large population study, and they only counted women depressed if they had either an ICD-9 diagnosis of depression, or if they had a prescription for an antidepressant. So they didn't really screen for symptoms at all. They just looked for those two things. But you can see how that would really underestimate the number, which it did. But the other thing is, they said, looking at obstetricians, that they were significantly more confident than pediatricians that they could identify depression without a scale. So again, the OBs were kind of looks like the most likely culprit. They said in a survey and chart review study, all 47 respondents agreed that it was their responsibility to screen for depression, and 94% of them were confident that they could diagnose it. But very few were actually using any kind of standard instrument. And they said that they used the Edinburgh Postnatal Depression Scale in 39% of the visits, and in counseled their patients in 35%. So again, they said the residents actually had the lowest rates of screening, only 17%. And that's a kind of somewhat concerning, considering you're thinking, okay, these are the younger physicians and they're going to be more up on the current stuff. They weren't. They said 42% of the attendings referred, compared to 67% of the certified nurse midwives and 94% of the nurse practitioners. Okay, so again, they were trying to see the effectiveness of their policy on universal screening at a local medical center, but unfortunately, you can see there's a pretty significant gap. And it's concerning, especially because the younger physicians, particularly, had the lowest rates. So, what are the clinical takeaways of this? First is that screening is a necessary first step, and mothers cannot be treated at all if practitioners don't know they're depressed, and they're very poor at actually guessing. But simply mandating screening, either through policy guidelines or even hospital guidelines, is unlikely to increase compliance. That providers need to understand why it's relevant to their clinical practice, and there should be institutional support. And again, this applies to everybody. So, let's say you're a breastfeeding organization and you want to screen. Okay, what are going to be the next steps? And is there institutional support for it? Do you have policies in place, but also kind of follow up to make sure people are actually doing it? Okay, and they said that, one of the things they found that was helpful is, especially in healthcare settings, if there are electronic prompts that providers can see in their charting system that will actually remind them to screen. But there also needs to be a clear plan of what can happen when mothers screen positive. And they said providers are more likely to screen if they know what to do next. And I think actually that's a really important point, because I think nobody likes to think that they don't know what to do. And if they find somebody who does have symptoms of depression, particularly significant symptoms of depression, you want to make sure that somebody's going to be taking care of the mothers, and you want to make sure you know what to do. Because otherwise you kind of feel like you're incompetent. You don't have any idea. You've opened up this box, and mothers are upset and you don't know what to do. So again, you're not going to really, if that happens to you once, you're probably not going to want to screen again. So what we want to do is have a clear plan. Okay, if this happens, this is the protocol and this is what we're going to do next. Okay, so in the next session, I'm going to talk a little bit about how to pick a good scale and what are the kind of pros and cons, because, there are several scales that people use, but I also really want to, sort of emphasize what is a screening scale versus a diagnostic tool. Okay, so remember, a screening scale is just the first step. You really can't make a diagnosis based on these tools, but it will tell you if you need to do further, if you need to, take other steps. And that actually, I think, will be something important to know. And also to be thinking about, what are your goals of screening? Are you in a situation where you have limited resources, or do you think you want to cast a broad net and cast to everybody? And honestly, there's pros and cons of both. Obviously, I'd like to see the most women being treated, but if you only have very limited resources, how can you actually adapt for that situation? So we will cover that next time. I hope this has been helpful for you. I really just kind of wanted to put it out there that these are the things people think when they kind of hesitate to do that. So if you're feeling that way, if you're feeling like, I haven't even wanted to undertake this, I hope I've convinced you that, okay, if we have a good plan, I think this will seem like a much easier and system to implement, and that's something that will actually kind of help move things along, but also getting mothers the help that they need. I think that's ultimately the goal, and so it's really within everybody's purview who actually talks to mothers, but how you choose to handle that, there can be some variance in that, because maybe you have staff administer and score the scale, and then the provider follows up. So there can be a lot of variations of how to do this. But I think the important thing is to have kind of an openness to be willing to kind of take that first step. And then we can kind of talk about, okay, what's the next thing you should do? Okay, so with that, I'm going to wrap up this session. I hope this has been helpful. Tune in for the next one because we're going to actually talk about the scales. So until next time, thanks so much, and I will see you soon.